So I am Siobhan Morse. I am the Division Director of Clinical Services of UHS, called Foundations Recovery Network. I loved the conversation about the testimonials that you guys just had, and the prior conversation about branding and all of that. You know, and at the end of the day, this young lady here said something that speaks so close to my heart: objective data. You know, and so testimonials do pull at our heartstrings. Testimonials are amazing. We love testimonials. We love to see that patient or that family member who's like, I got my life back, or I got my son back, or however that looks. But have y'all ever seen that Jenny Craig commercial where she's like, I lost all that weight, and she's dancing, right? And then have you seen what goes down at the bottom of the screen? Yep, results not typical. Individual results may vary, right? And so that's a really big consideration, especially in an industry that I think one of the Chris was talking a little bit about some of the history and reputation. You know, behavioral health in general has always been considered this soft science, and that is not so. When I was at university working on both my bachelor's and my master's, I happened to connect with the editor of the Journal of Consulting and Clinical Psychology. I mean, that is some real objective, statistical, hard fact data and information journaling. And there's a lot of it out there. And so being able to kind of bridge that gap and being able to speak to both sides of that conversation, I think, is a really important part of the marketing piece, both to families, because that is the, like what Chris was talking about, the go for it. You know, like really looking at your data and saying, so how am I doing? What's going on? You know, actually having the data to look at and being able to feed that information back into your system. The financial limitations, so there was a period where we had some pretty good coverage and we were building towards younger people, young adults, maintaining and keeping coverage, and then things changed again, and many of them have fallen off of their parents' coverage. Readiness to change, motivation, that whole world of literature, DiClemente, Norcross, Prochaska, stages of change. So has anyone here ever made a New Year's resolution? Right? So remember what December looked like before that resolution took effect, right? So any type of change, right? We go through different stages on our way and then in entering into that change. Life skills, their ability. So for those of you who know about recovery, there's two primary 12-step fellowships that are pretty well famous. There's like AA and NA. AA is Alcoholics Anonymous and NA is Narcotics Anonymous. There's lots of other fellowships and lots of other support programs that are great. But one of the things that we distinguish is people generally who go to AA are getting their life back. They're being rehabilitated. They actually had a life they lived. Many of them have had a job, you know what I mean, they got through. Mostly NA is filled with people who are being rehabilitated, like first-timers. Not first-timers in recovery, first-timers in life. They've never actually had, and that's our young adults, right? They have never really had the experience or the wherewithal to live life as it shows up. You know, the coping mechanisms, the resiliency. We'll talk a little bit about the brain chemistry with that. To live life like that on a day-to-day basis, right? And so that's almost a habilitative conversation. So if you've worked with young adults who have significant mental health illness and/or substance use disorder illnesses, you might find yourself having to remind them that proper hygiene has you brush your teeth in the morning and the evening every day. I mean, really basic stuff. When you wash your clothes, your whites should probably be in. Okay, so you do need to wash your clothes, that'd be first, right? And whites are usually in one load, and then you do the colors in a separate load. Like, they don't necessarily always have experience with that because either their family took care of it or that's not been a priority for them in their life. That is not unusual, and I'm not talking about a lower educated or socioeconomic status young adult. I'm talking about a young adult that has college education that comes from a good family. That is not uncommon. So that whole world of life skills, emotional regulation, impulsivity, and just being overwhelmed. I mean, recovery from either is scary. Life begins and it's overwhelming. There's just a lot even if it's all good, right? It's scary. Like, what do I choose? What path do I go? And I think that especially for our mentally ill young adults, sometimes that is actually the hardest piece, is there are opportunities and it's overwhelming. I don't know what path to take. And it's that someone, I think Dax mentions analysis paralysis. Like, I'm just going to do nothing because I don't know what to do. And you get that whole failure to launch and everything that comes with that. Patient family experiences of their family members' progress, just fear, social immaturity, and then lots of times negative support groups. So the median age of onset for substance abuse disorders in the U.S. is 20 years of age. Anyone here who has dealt with young men who have had first psychotic episode, first evidence of schizophrenia? No, it's 17, 18 years old. That first begins to show up. And what do? Somebody said it. They start smoking pot. Like that is really, really common. They start smoking a lot because it just kind of normalizes them. Right? And so, looking at that, they're just not in a place. And so family members don't understand what's going on. I've seen where the young man then falls in with the wrong crowd and is being led into and on a journey that is definitely not, based like his background and where his family is from. And so being able to recognize that, being able to intervene and not shaming. So that whole break the stigma. Like not shaming for the substance use piece. And really also making that distinction for yourself inside of the difference between dependence, substance abuse, and a substance use disorder, right? There are distinctions. And being able to speak to those distinctions and being able to craft and create treatment plans. Someone else is going to come up after me. I'm excited and talk about treatment planning. But being able to create treatment plans that meet that patient where they're at. Not where you think they should be or where you think they should go, but meet them where they're at right now so that you can set that foundation so they can move along that continuum. According to SAMHSA, the rate of substance dependence among young adults 18 to 25 is higher than among youth or among age 26 and older. So 18.6% of 18 to 25 years old, 20%, 1 in 5 18 to 25-year-olds is using. That's is not just using, but is dependent and abusing drugs. 1 in 5. That's what that number is telling you. You think there's an issue here? And we know that co-occurring is such a large part of that. Again, if I never feel like you guys all look, and I find something that makes me feel more like you seem, I'm going to go with that. And that's exactly what self-medicating is. It's not like they're sitting there with the list of their symptoms and pharmaceutically trying to fix that. They're like, it makes me feel like you look, like you act, and I can be okay with that. And so really getting that again inside of that conversation of destigmatizing. Young adults have the highest rates of use of prescription opioid pain relievers and stimulants for the treatment of ADHD and anti-anxiety drugs. Heroin use among Americans 18 to 25 increased 109% over the 4 years between 2009 and 2013. The reason that we are even having a conversation about opiate use disorder is because moms had enough. Because grassroots moms said, I am not going to cover up what's going on with my son or my daughter. Moms simply had enough. That kid who was the football player that got the knee injury and then got a 60-day prescription for oxys, 60 days. Hi, dependence is not a disorder. Dependence is an expected side effect of the use of opioids. That's how that works. And unless we address the dependence, once somebody has been on opioids, you're going to move into a use and abuse. The brain is basically, so 6 months later, on MRI, there is nothing wrong with your knee. What is wrong with you? Why do you keep taking this? There is nothing wrong with your knee. It still hurts. That is not a fabricated or fake pain. It still hurts because the pain doesn't happen in the knee. The pain happens in the brain. And you have damaged the circuitry in the brain by using the prescription opioid such that the brain still believes that there's something wrong with the knee. If you're interventional pain management specialist. That was just an overview, like explanation of it. There's a lot going on. But in general, what you have created is what some literature references as reward deficiency syndrome. You have broken the endorphin and the dopaminergic systems of the brain through long-term. That's why the FDA finally said, okay, actually, and CDC, actually, okay, long-term chronic pain, probably don't want to use opioids. Because you break the system and it actually propagates more long-term pain. So anyway, 9 in 10 people who use heroin use it with at least one other drug. Most use at least 3 other drugs. So here's what's really interesting. Since 2013, we looked at our data, and it's amazing the difference in the opioid user. 5 to 7 years ago, the opioid user was primarily prescription, and that's what they stuck with, and they weren't using a whole lot else, maybe some alcohol. Now, with the shift to heroin, polysubstance use is huge. Like stimulant use among opioid users is 3 times greater than it was 5 years ago. This is in my population, but SAMHSA data shows the exact same thing. Shows a really similar. The sedative use, which, okay, really bad combination, taking sedatives along with opioids. Like Xanax mixed with oxys or heroin, really bad plan. That is just your recipe for death. You're gonna die. That use is through the roof as well. Psychedelics, and then other substances as well. So what we're seeing is much, much more severe polysubstance use in our young adults especially. Alcohol use prevalence and episodes are the highest. I mean, the whole binge drinking conversation. You see the beginning of some sober dorms. I think that's fabulous. You know, creating supportive environments for people who choose to remain abstinent or who are in recovery on our college campuses. Because it's really hard at 19 years old to have a social life and be like, yeah, I don't touch the stuff. How do, you know, the reason you were drinking so much was so you could fit in. So this is such a critical period, though, of brain development. And it's also that period where you're supposed to take those risky behaviors. You know, in an evolutionary sense, this age group, you are your strongest, you are your fittest, you are your most able to heal. You are supposed to take risks. You are supposed to be the one who goes and faces the saber-toothed tiger and, you know, gets the meat. You know, I mean, but that's what you're designed for at this time. And so, you know, finding that balance, right? And everybody knows that kid from college who never stopped, right? Right? So a couple of people were like, yeah, right? I mean, or maybe you're that person and it got better, right? But, you know, there's all those people who go ahead and take those risks and do those crazy things, and then, like, they graduate and they're like the most normal, like, wearing a tie to work thing. And then there's those that don't. And we really don't have a good way to forecast that at this point. There's some issues, things like ACEs, and there are some things we can look at, but in general, we don't. And so really being protective of that time period and understanding what's going on with the brain chemistry when you're dealing with those patients. I would suggest looking at anything by Kenneth B-L-U-M, Kenneth Blum, said Bloom. He's the guy who found the first addiction gene. He's the who's one of the people that's coined the term reward deficiency syndrome. Brilliant. It really talks about the dopaminergic systems in ways that people can understand. And so we do an exit survey on over 70% of people who participate in our treatment at different levels, complete an exit survey. And so what we did is we took the older adults and we took the younger adults. Anyone over 26, we called an older adult, I know. And then 25 to 18, we called the younger adults. And we said, what are the differences in what they are satisfied with or what they like and don't like? Right? And so it's not that they were dissatisfied, but they scored these 10 items lower. So availability of medical staff, availability of psychiatric nurse, availability of staff in an emergency, availability of daily physical activities, level of respect with which I was treated, professionalism of the staff, communication between staff, communication among staff, usefulness of the handbook, and meals. Okay, so kind of put meals to the side because that's what it is, but everything, okay, sorry, right, whatever. It's just really funny to me because here's the 18 to 25-year-olds who understand what the emergency crisis, how that should be handled by my medical staff. Not my 37-year-old doctor who came to treatment who's saying this. It's the 18-year-old who To me, it has really so very little to do with actually what they're saying, the specific item. This is more like, you're not paying attention to me. That's truly what I got out of this. I don't think you're going to be ready when this blows. Are you noticing me? Did you hear me? Am I important enough? And if you really consider the 18 to 25-year-old, late adolescence or young adult dilemma, that's actually a lot of what's going on. This being able to feel that we have an impact, that people notice us, that we're there. And when you consider the isolation of mental health and substance use disorder, that even becomes, bigger and more important, because I've felt so invisible for so long. Perhaps purposefully, but I have felt so invisible for so long. And so when you're talking about young adults and when you're dealing with young adults, what I have found and what we've worked with our milieu staff on is, so with anybody, but especially with the younger adult, doesn't matter how busy you are, if they need to tell you something, do your best to either stop now and listen, give full attention, right? Or tell them, I cannot do this right now, but I will get back to you, and get back to you. Like, follow up. Even if you're like, I didn't forget, I'm still busy, I will get there, right? To have, that's what they need. Think about Facebook. I post something, and within minutes, I want to know if you like it or you don't like it. Like, I want immediate feedback on this emotion that I'm having, because that's how I am. Right? That's, you know what I mean? That is kind of the social milieu. And so now you're in this treatment center, you're receiving therapy, and someone's just listening. No, you're not hearing me. You're not getting me, right? What the expectation is some level of immediate feedback, so that I know, I can confirm that I've been heard and I have been seen. So all of those tools, restating, all of the tools that we use, but being vocal with them, having that, which is different often, most often being in session is listening, but actually being engaged with them. So when we talk about substance use treatment, it's a process with multiple different levels. One of the most important things is that people should be able to enter, young adults and anybody, at any level that is appropriate. So there's two things that are going to, several things actually, that are probably going to define appropriate. The first is going to be actually what level of care do they need, right? Second is going to be what level of care are they willing to accept, and finding a bridge there. And especially in your young adults, finding that bridge, that's really important, because there's so many of them also who are either A, the failure to launch, or B, the total overachievers, right? And being able to manage that and bridge that as well. And so these are quotes from some of the literature, so there's evidence between participants. So what this speaks to, these quotes have to do with extending that continuum. So regardless of where somebody enters the continuum, they should be able to also traverse the continuum in either direction. So they entered the continuum in residential, they did really good, they stepped down to PHP and they're living in sober living, and now they're going to and they're doing day treatment. Now they're going to an IOP and they had a bump in the road. Do they need to go back up to PHP? Or they entered the continuum with you in a private practice, but maybe they need a little bit more than simply session, and they need to be removed from their environment for a short period of time. Being able to do that and then come back to practice, to just once a week or 3 times a week or whatever that looks like. And participating in groups separately or as part of, but being able to be really creative and utilizing that entire continuum, especially now with, I don't even get the acronym, OBOT, right? Office-based opioid treatment, I don't know. Office-based treatment and medication-assisted treatment is really creating even a larger breadth of possibilities within the continuum as well. So this is one of my favorite things, Moose, Schaefer, and Jossie and Moose. So to be honest with you, the duration of treatment, right, the length of time somebody is involved in therapeutic processes is the most important factor in terms of long-term recovery. It is not the intensity of the treatment. Just extending how long they're actually involved in the therapeutic process makes a difference. 2 main features of the recovery perspective, and so I put this up as opposed to the curative perspective. right? So as a nation, we are still so enamored with the fact that in the 1940s, we created pills that would miraculously cure people, like overnight, that we have basically relied on that as our entire system, right? And we see everything as being curable. And that's simply not the way that the diseases that we're dealing with, both physical and mental, right, happen now. Long-term chronic illnesses, such as anything in mental health, and I'm willing to classify hypertension, obesity, heart disease, diabetes as long-term behavioral health issues. That's where we are right now. So medications support, right? But it's not a curative. Most of everything we're dealing with. And so substance use and mental health, although they've been seen separate, they're actually very similar to these types of diseases that we're seeing. Long-term process of internal change, and internal change proceeds through various stages. That's straight out of SAMHSA's Tip 42. SAMHSA, the Substance Abuse Mental Health Services Administration, their treatment improvement protocols, which is integrated treatment for persons with co-occurring mental health and substance use disorders. Tip 42, free online. Sorry? 42. Tip 42. If you Google TIP 42, it is free online. They have an executive summary, they have the big book, they have a whole world of resources for dealing with co-occurring, integrating treatment for co-occurring disorders. So why do people change? So there's a bunch of work done by Miller and colleagues that talk about why people change. And at the end of the day, so placebo hope expectancy, right, hope, right, is 15%. The technique that you're using, so the example I always give is whether you're doing seeking safety or EMDR, right, it's going to count for about 15% of the variance of why people change. The two most important things, 30% is accounted for by the relationship that you build. Right, so that includes both therapeutic alliance as well as the other relationships in your patient's life. This is especially important in the young adults. So I did a mental health statistics improvement project, a demonstration grant for NIMH years ago. We were up in Delaware looking at the severely and persistently mentally ill, and what we were trying to do is develop we had a 12-item instrument that we were using to try to predict if someone would go into crisis or not. So we did analyses on these 12 items. And what do you think? I mean, so I have a home. I see my therapist regularly. I take my medications, blah, you know, all those 12 things like that, 12 domains. What do you think was probably the single most important factor in predicting crisis, no crisis? Support system, exactly. The relationships in their life. Even if they were homeless, even if they never took their meds, the single most important factor on determining whether or not someone went into crisis is if they had a positive support system. That's how important relationships are. So it's not just the relationship you have with them, which is very important, your patient, but it's also the relationships that are in their life. Family therapy and bringing the family in when it comes to co-occurring treatment is an evidence-based practice. We have known this since the 1980s. The Johnson Woods Foundation has listed it, you know, bringing the family as part of the treatment team in. Sometimes that looks like not the biological family, but the patient's self-proclaimed family because the biological family is a negative influence. And the patient says, no, I have these really close friends. That needs to be your family of focus. Then that's where you go, right? Sometimes we need to let the patient determine what really is the family that's positive for me and what that looks like. And then finally, extra therapeutic. So the other stuff. Do they feel valued when they walk into your office? You know, we were showing some tours and pictures. And so does it feel comfortable and warm and inviting? Right? Does it, you know, there's all, extra therapeutic is that whole world of stuff that you don't normally think about in the therapeutic setting, but that makes a difference, those cues that we have, right? So really walking around with a new eye for where you practice and how you practice and your teammates, the interactions that you have with your teammates, you know, separately from the patients, all of that extra therapeutic. 2 young adult studies, we'll go quick. Okay, one is 1,972 patients entering treatment. Basically, so how many people have ever stayed in a hotel room? Ever, right? How many people know that you always get a survey that asks you about your stay in the hotel room, right? How many people fill out that survey? Okay, I got 3. Somebody, Dax, I think, or Chris said 4 to 5% of people do the surveys, right? So if you want reliable research, according to SAMHSA, you need 60% of people to tell you, you need to reach the 60% of people a year later, right? Or across that year. We reach out to people, 80% of people or more need to be enrolled in your research program or in your program evaluation. That's kind of what SAMHSA says, right? And then you need to reach 60% of them at the end of the day in order to see what their outcomes are. Does that make sense, right? Really different from 4 or 5% that is the general response rate, or the 2 to 3 people out of this room, right, which is 1 or 2% that respond. So at FRN, we're very proud of the fact that we're able to reach 60% plus at 30 days post-treatment, 60 days post-treatment, and a year post-treatment. What that means is that we don't have to write individual results may vary, right? What that means is this is objective data. All right, so out of those 1,972, full disclosure, young adults are really hard to reach a year later. I chose the 6-month time point. The data that we'll talk about is going to be primarily at a 6-month time point. Secondly, there was we did an impact study. We used a random number generator. We did all these statistical things, blah, blah, blah. End up with 100 patients just so we could kind of get a pilot sample and get an idea of the difference between length of stay and length of engagement and extending those continuums and what we can expect when we do that. We'll talk it through as we go. Again, you'll have the slide deck. Length of stay is used to describe how long you're in a single level of care. For example, you're in residential treatment or in the hospital or in a detox center. That is a length of stay. Make sense? Length of engagement is how long did you stay involved in the continuum? So did you go detox, res, PHP, IOP, back to res, back to, you know what I mean? How did that work? How long did you stay? So in the impact study, we looked at all 3 of them. Length of stay, so 1 month post-discharge, there's a relationship between staying in that residential level of care longer and a decrease in the past month use of alcohol and decrease in depression inventory scores. At 6 months, after treatment, so what we're talking about now, 6 months and 12 months, and this is the impact study, right, is sustained results. Right? So when you stay longer in res, you get better sustained results. So you got a decrease in using alcohol, you got a decrease in frequency of opioids and sedatives, fewer suicidal thoughts, fewer suicidal attempts, and better scores on anxiety and depression. Right? So this is not people who necessarily extended, these people are only people who just stayed longer in res. You get that? And at a year, you see there's a relationship between less frequency of sedatives and inhalants past month, and so it's cumulative. You get that? You get everything from the prior time point plus. So if you went to residential and you went to any outpatient, like the next level of care at all, you had these benefits at 6 and 12 months, right? The more reported outpatient days, so it was a direct relationship. So if you went to residential, the more days that you added on in terms of going to the next level of care like an outpatient, the better your results were on these specific items. Decreased anxiety, increased attendance at self-help meetings, increased use of sponsor, fewer days intoxicated, more days working, right? And higher importance placed on your legal problems. You were living your life. You were facing the issues of your life, and you were living your life as designed and as it showed up, right? And so the more that we can, so at the end of the day, really, that looks like a relationship, right? So when someone goes to res, or when you refer someone to res, or if you have someone who might need res, the idea is to build a relationship so you can get them back, because the longer that they continue after that episode, after their length of stay, the longer they extend continued care, either with us, with another provider, or back to you, depending on their severity at that discharge point, the better the results are going to be. That's, at the end of the day, why we're all here, right? Is building those relationships. That's what marketing's about, is building a relationship. And then finally, when you look at it together, so longer lengths of stay and more engagement, meaning staying, attending to outpatient or the next level of care more, resulted in even greater benefits, right, at 6 to 12 months. Fewer medical problems. I mean, basically at all aspects. So what happens is the more that they address in a res setting and then have continued care, the more areas of their life they're able to address and manage. So we broaden the depth and the scope of what's impacted. Thank you. Awesome, thanks. Thank you so much for having me.